Let's start to understand primary immunodeficiency. So, primary immunodeficiency, we can shortly understand it by this chromosomes. Wait, yeah, I'm a little sick today, so don't mind me. Okay, so primary immunodeficiency. Primary means it can be the cause of other things, okay? It is not due to some other things, some other predisposed things, right? It's primary. It causes other things. Immuno means we know immunodeficiency, we understand. So, failure of development of third and fourth pharyngeal pouch, right, due to 22q11 mutation. Okay, now this is a weird name, 22q11. Now usually 11 into 2 is equal to 22, so that's how I remember. And fourth pouch, these third and fourth pharyngeal pouch are responsible for formation of your spleen and your B cells and your T cells and your thymus. So that's why this thing, the George syndrome, is in short is primary immunodeficiency, right? Okay, let's talk about the presentation of DeGeorge syndrome. Well, presentation is that your third and fourth pouch is messed up. It means your T cell deficiency will happen, right? Because third and fourth pouch make your thymus, right? So T cell deficiency, problem fighting viral and fungal infection due to lack of thymus, of course, as thymus develops from third and fourth pouch, right? Hypoglycemia, it means low sugar in your blood, right? It's due to lack of parathyroid hormone, right? So no reabsorption. So we know PTH, right? It can cause a lot of things, right? PTH is potassium thrashing hormone. It's not potassium thrashing hormone. It removes the potassium from your body inside the urine, and it reabsorbs the calcium from your bones, right? Let's try to understand what really happens, because let's try to understand what is DeGeorge syndrome. So we understand there is some sort of developmental problem, right, in this. So when I say that there is 2211 mutation, I mean the big picture is that there is some micro deletion on chromosome number 22, right, and especially at Q11.2. So in short, it's 22q11, but actually it's 11.2, right? And what happens is that it's just chromosome number 22. It's the Q arm. Q arm, it means long arm, okay? Long arm, that's the thing. And region number 11.2 is deleted, right? So what happens? It happens that third and fourth pharyngeal pouch are deleted, and what happens is the third pouch makes thymus, right? Thymus plus it means inferior parathyroid, okay? Parathyroid glands, okay? PTH. And okay, so this is the third. And fourth, it makes superior PTH, okay, plus it make some thyroid, okay? So if your fourth and third are messed up, it means you will have messed up PTH and thyroid, okay? So what's the silver lining? So let's try to understand that what PTH normal does, right? Lack of parathyroid, right? So the word PTH, it means parathyroid, right? What it actually does is that it increases bone reabsorption, right? It increases the plasma calcium levels. It increases the kidney calcium reabsorption, right? It decreases phosphate reabsorption. It is a phosphate thrashing hormone, right? So what happens is that it increases something called as 125 OH, vitamin D, which is calcitriol, okay? This is a calcitriol, and it increases the absorption of this, right? And it doesn't increase the absorption, it increases these levels, and then this calcitriol actually, results in increase in calcium absorption, right? So here it's a hypocalcemia. Okay, hypocalcemia, we understand hypocalcemia means less calcium. Okay, so I hope you understand abnormalities of heart and greater walls and faces. What does it mean? Well, abnormalities of heart. What is it? So first thing is hypocalcemia, right? Second is T cell deficiency, right? And third is abnormality of heart. It means there will be some sort of congenital heart defects, especially I think in the aortic arc, right? In we can also see, I think, tetralogy of Fallot, right? And we can also see truncus arteriosus. Okay, so these three things can happen. So these three things can happen. This is the triad of DeGeorge syndrome. Let's keep going on. What is SCID? Severe combined immune deficiency. So note, it is a combined immune deficiency. Patients have defective cell-mediated and humoral immunity. What the hell is cell-mediated and humoral? Cell-mediated, it means it is mediated by the cell, right? Which cell are we talking about? We are talking about CD4 and CD8. It means they are mediated by thymus. Okay. Humoral antibodies, humoral immunity, humoral. It means humoral. What is humoral? Humoral is body fluid, right? And body humor, right? Aqueous humor. Have you heard about it? So humor comes from body fluid. Body fluid comes from B lymphocytes, right? Lymph. What is lymph? Lymph is a water-like substance, right? The exact meaning of lymph is a water-like substance. So B lymphocytes, right? And we know that B lymphocytes can, produce Ig, G, E, right? These immunoglobulins. So both T and B, right? Okay. So combined means both are messed up. Etiology, cause. First of all, cytokine receptors defect. Main cause. We know what are cytokines, right? And other thing is adenosine deaminase deficiency. Well, the second main cause is this adenosine deaminase deficiency, and this adenosine deaminase this enzyme is necessary for deamination of adenosine and deoxyadenosine. Now, if we have lack of these enzymes, right, adenosine deaminase, adenosine and deoxyadenosine accumulates in the immune cells, causing toxicity, right? Let's try to understand this a little better. So what is adenosine? Adenosine is a purine nucleoside, right? It's basically adenine. What is adenine? Adenine is a nitrogen base, right? And ribose, it's a sugar. So what happens is that it's a nitrogen base. This adenosine is a nitrogen base with some sugar. Now think of it as a building block of DNA and RNA. Okay, now this DNA and RNA are made up of these adenosine and deoxyadenosine, right? So from adenosine you can make AMP, then from AMP we can make ADP, and from ADP we can make ATP, right? ATP is energy, and deoxyform is just DATP, right? Deoxyform used for DNA synthesis. So adenosine sits at the center of purine metabolism cycle. I hope we understand this purine metabolism cycle. Now, what is adenosine deaminase? It's an enzyme in the purine degradation pathway. It's found in most cells, especially in all the B cells, in all the lymphocytes. Now, its function is that it converts adenosine into inosine, right? And it also converts deoxyadenosine into deoxyinosine, right? By removing amino group, by removing this nitrogenous NH2 group, right, from the adenine group. So if we don't have this sort of deaminase, if we won't be able to convert, right, this we won't be able to convert this adenosine into, into inosine. Okay, I'm a little sick, but so if we are not able to convert that, it means we cannot make ATP, we cannot make DNA, right? So we will have accumulation of these two things, adenosine and deoxyadenosine, right? Now these DATP and this adenosine are very toxic in development of lymphocytes because it inhibits ribonucleotide reductase. Now, this radionucleotide reductase is needed to make deoxynucleotides for DNA synthesis, right? So, no DNA synthesis, and without this DNA synthesis, lymphocytes, T cells, and B cells cannot divide, mature properly, so they'll die off, right? So, the result is very severe combined immunodeficiency, right? Adenosine deaminase. I hope we understand this. Other thing that can happen is MHC class 2 deficiency. It means CD4 won't be able to get activated because MHC class 2 deficiency. MHC is like this molecule on which you can show antigens, right? So MHC class 1 we use for CD8 and MHC class 2 for use for CD4, right? Okay, what is the presentation of SCID? Well, it's a combined. It means there is cell-mediated and humoral problems. So lack of T cells, lack of B cells. T cells especially is good for fungal and viral. B cells for bacterial. B stands for B bacterial. And increase opportunistic infection. And opportunistic infection means fungal, right? And to be very, very means to be worried to give live vaccines because they actually don't have any sort of immune system in themselves. So that's why I don't give them vaccines. Treatment of SCID, sterile isolation, just keep the, temporary, it's a temporary treatment. Another permanent treatment is the stem cell transplant. We must transplant these stem cells so that they can start making good, cytokine receptors. We can, heal them. We can heal adenosine deaminase, and we can, start producing good quality MHC class 2. So treatment of SCID is this. What is X-linked A-gamma globulinemia? What is the mutation? It's a cool question. The name suggests the patient has X-linked, right? A-gamma means, okay, let's lacks gamma globulin, right? Antibodies in the blood. There's a complete lack. There's no gamma globulin, right? It occurs because naive B cell can't mature, right? This mutation is Bruton tyrosine kinase, right? And it's a signaling. Mutation happens at Bruton tyrosine kinase. It's a signaling receptor that helps in maturation of B cells, right? So let's try to understand this gamma globulin shit. What is globulins, by the way? So when we take blood plasma and separate its protein and electrolytes, and we do it by a process called electrophoresis, right? What happens is that we get 5 major things out of the blood. First is albumin. We get then we get alpha 1 globulins. Then we get alpha 2 globulins. Then we get beta, and then we get gamma. So what happens is that in this X-linked aglobulinemia, there is these gamma globulins are not present. Okay. Now, this gamma globulin is really, really, really important for adaptive immunity. Okay, it's really important for adaptive immunity. Adaptive immunity means it tries to understand what kind of viruses. It's immunity with some sort of history with it, right? It's an intelligent, immunity. So gamma globulins are simply these are just plasma protein that contains antibodies on them. I hope we understand that, right? So these gamma globulins, right? These gamma globulins can be of IgG, IgA, IgM, IgD, IgE, right? We know that E is for allergy, D is for B cell receptors, and IgM, these are like the acute phase, gamma globulins. IgA, they are found in, saliva, tears, right? And G is the long-term, responders. So if we don't have, we just don't have this, we don't have any immune system, by the way. So I hope we understand this, what's happening. It happens because of a Bruton tyrosine kinase. This is a process in which the production of these, not production, the maturation of the B cells happens. So there is mutation at this place, Bruton tyrosine kinase, and then we have A-gamma globulinemia, right? What's the presentation of X-linked A-gamma globulinemia? What is the presentation? If we don't have, these IgA, IgE, IgD, IgM. We don't have. What will happen is that we will have functionally no immune system, right? We will have a recurrent bacterial, we will have a recurrent enterovirus, we will have a recurrent Giardia infection, right? Now, this Giardia, wherever Giardia is written, it's for IgA, okay? Because IgA is found in saliva and in gut, right? So, Giardia is for IgA. Enterovirus is also for the gut, right? So, IgA also present in saliva and the gut, right? On the lining, right? So, enterovirus and Giardia. And other thing is that IgA protects mucosal surface, right? So we know that IgA results in enterovirus infection. Giardia occurs in the same reasoning as enterovirus because both of them are for the gut. Presence after 6 months of life because till 6 months your mom's antibodies are working. So again, I would vary to give them live vaccines. Don't give them live polio vaccines because it can actually cause big problems, right? Because they effectively had no immune system. Okay, what is a common variable immunodeficiency disease? Common variable, it's a variable. How? So patient has low antibodies due to defective B or defective T, right? It's a variable. Either B is messed up or T is messed up, right? What's the presentation? If B is messed up, it means you will have a lot of bacterial and protozoal infection. If T is messed up, you will have fungal or viral infections, right? So bacterial enterovirus, Giardia infection, often in late childhood, right? They have increased risk of autoimmune disease and lymphoma. Okay, that's very high heel. Lymphoma. Okay. Cool. Very easy chapter actually, I think. Okay. Let's see. What is IgA deficiency? Now, I already told you that IgA is found where? In the mucosal lining, right? And we know that these are enterovirus and Giardia, right? So the most common IgA deficiency, this IgA is the most one, right? Patient have low serum and low mucosal IgA, which increases the risk of mucosal infection, right? And we know that mucosal infection is enterovirus, Giardia, especially viral ones, right? Okay. Note the patient with celiac disease usually have IgA because celiac disease is actually a mucosal risk, right? What is hyper? Hyper means up. IgM syndrome. So patient have too much IgM, right? So imagine if they just have IgM. If they have IgM, they will have this acute gamma globulin, right? Antibodies, and they will not have other classes of antibodies. No class switching, right? So no IgM, no IgG, no IgE, no IgA. They essentially have nothing but IgM. So no class changes. Naive B cells, they make IgM and IgD. We know that. So again, patient will suffer from these things, right? I hope we understand that. Okay. What is the pathophysiology of hyper IgM syndrome? What is the presentation? Mutation in CD40 or CD40 receptors, right? Why? So mutation in CD40. Let's try to understand this thing before we try to understand this. I'll try to give you a little bit background. So what happens that every B cells make IgM as its default antibodies. Okay. Later under the influence of helper T cells. Okay, it can change the class. It can change the class switch. Okay, it can switch from IgM to IgG to IgA, IgE, depending upon the cytokines it receives. Okay, so if they have hyper IgM, they are messed up. They just have just IgM. Okay, now we understand what is class switching, right? We understand what are the triggers, right? So the number one trigger is T helper cells, right? That helps in class switching. Okay, now we know that T helper cells express something called as C40 ligand, right? And we know that C40 ligand, CD40. Now CD40 ligand has a receptor called CD40 receptor, right? And this CD40 ligand goes and binds with CD40 receptor, and then a second signaling molecule is created, and then a second signaling happens, and then they can switch classes. Okay, so that's the That's the concept. When they bind, like these CD40 and CD40 receptor, when they bind, they activate something called as cytidine deaminase. Okay, and then it turns on this DNA recombination, and then the switching of class happens. Okay, so if this is not working, the CD40 ligand plus CD40 receptors is not working, they will not have, class switching. If there is no class switching, they will have low levels of IgA, IgG, and IgE, right? The presentation is recurrent pyogenic infection because bacterial infection again and again are happening because they have bad levels of IgG, because IgG is the long-term gamma globulin. So it's keep happening, right? Especially at the mucosa site. IgG is opsonine. It means it helps in phagocytosis. Low amount result in more formation of pus. So less phagocytosis, more formation of pus, because the neutrophils in acute inflammation, they cannot completely phagocyte the bacteria. They cannot completely phagocyte the antigen, and once they try to phagocyte, they themselves shuts off. They themselves die, and then this fluid plus neutrophils, whatever. This results in formation of pus. So that's the concept of pyogenic and IgG. There's the concept of this CD40 and this receptor. This is the concept of hyper IgM syndrome. Okay. Another question is, what is Wiskott-Eldridge syndrome? Okay. Now this Wiskott-Eldridge syndrome and Wiskott-Eldridge syndrome, right? WASP. So I thought it's a WASP, so I made the WASP. What causes it? Just memorize. Okay. So what causes? Let's try to understand it. Patient have something called as thrombocytopenia, right? I'll talk about it. Eczema, marks, and recurrent infection. It means something wrong with their IgG. Now patient have defective humoral and cellular immunity. Both are messed up. It's like a primary immunodeficiency disease, right? And it happens due to mutation is WASP. See, Wiskott-Eldridge syndrome protein gene, and it's X-linked. X-linked means women can be the carriers. Okay, so let's see what I have written. This Wiskott-Eldridge syndrome, it's a hemopoietic cell, right? These hemopoietic cells, they make our immune cells, right? So these cells, they messed up. So what will happen is that we will have small platelets, right? Thrombocytopenia. So we will bleed a lot. Other thing is that the Th1 to Th2 ratio. What is this Th1 and Th2? These are T helper cells, right? So Th1 and Th2 ratio is messed up. So we will have more levels of IgE, right? And we will have more levels of IL-4, interleukin 4. So I hope, okay, let's go back a little bit and try to remember what was Th1 and Th2. So we know that Th1 makes IFN gamma, that makes macrophages, and Th2 makes IL-4, IL-5, and IL-10. IL-10 is, interleukin 10 is anti-inflammatory, but IL-4 and IL-5 they are used for switching of classes. So if we have more levels of Th1 and Th2, right? So imagine if we have less levels of Th1, we will have less macrophages, and we have more levels of Th2, we will have more class switching. So what happens that in this IL-4 levels are, they skyrocket, and then once they skyrocket, it means we will have a lot of IgG, the long term, and the allergy one, IgE, right? So that's the concept of WAS, WAS, right? WASP. So I hope you understand this. What are the consequences of following complement deficiency? Just memorize, okay? Okay. Deficiency from C5 to C9. Now we know that this is the complement system. We know that C3 makes C3A and C3B, right? C3B, and then C3B goes further in the pathway, and C3B makes C35A, and I hope we remember this. So if we have deficiency in, we won't be able to make something called as MAC, right? Now this MAC is responsible for the destruction of a lot of things, right? So increased risk of Neisseria infection. Now Neisseria infection is a bacteria, right? Neisseria, it's a bacteria, and what happens here is that it's a opportunistic virus, and so we'll have messed up Neisseria infection, and this is the concept behind it. So C1 inhibitor deficiency. What is C1 inhibitor? So it's an inhibition. It means it stops. Imagine if we don't have this C1 inhibition. This is a system that stops this complement, right? We don't want a lot of complement system happening because it will attack our own tissues. So C1 inhibition stops hereditary angioedema characterized by edema of the skin, especially periorbital and mucosal. Okay. Now, these are the breaks of C1. And so, what happens if we don't have the breaks of C1? We'll have up regulation of complement system, right? Now, let's try to understand this. What is C1 inhibition system? So, C1 inhibition system, it's a cool system, right? It's a regulatory protein. It's a regulatory protein, right? It's a break on your complement system, right? These are part of your innate immunity system, not the humoral one, the innate one. What happens is that when the complement gets activated, the C1, C2, C4, etc., right, it helps to destroy microbes, right? And imagine if don't have any breaks. So these complement system, they cause swelling, inflammation, vascular leakage, blah blah blah, these things, right? And if we don't have any breaks, it means it's uncontrolled. So to prevent this overactivation of complement system, we have something called as C1 inhibitory system, right? In short, we call it C1INH, right? So it's a breaking system, right? So I hope so it just keeps the complement system and the bradykinin, the kinin, the what's the word? Really heavy weight kinin breaks down into bradykinin, right? So it keeps the complement and bradykinin system under the control. So if we don't have this C1 system, what will happen is that a lot of excess bradykinin will be released, right? And then bradykinin are these big vasodilators, and they increase this vascular permeability at these venules, right? So what will happen is that a lot of bradykinin will lead to a lot of leakage of fluids, right, from the vessels, right? So what will happen that localized non-pitting swelling, right, around the eyes will happen, angioedema, right? And so this is the concept, right? So I hope we understand this, why it's happening. And the common site is periorbital, edema, right? It also, so cool thing about it is it's episodic, right? Every time we have activation of complement, we will have swelling. So episodic. It's non-pitting, okay? Very, very, very important. It's non-itching, okay? And common site, periorbital, around the eyes, lips, tongue, airway, because we know these complement system, they work around the airways, on the mucosal lining, and on the GI tract, right? So very important. Again, these all symptoms, these are histamine mediated, right? They are not allergy. Cool. There is no urticaria here. Okay, we don't have any sort of scratching here, non-scratching swelling. All right, that's very important. So trigger leads to overactivation of bradykinin and complement. Then this complement and bradykinin leads to a lot of vasodilation, a lot of vascular permeability, a lot of fluid leaks, a lot of angioedema. And this angioedema usually happens around the periorbital airway and the GI tract, right? On the serum, we will find some sort of increased complement system, So I think the number one treatment is to replace this missing inhibitors, right? And to stop the bradykinin system, right? So that's the whole concept of C1 inhibition deficiency. All right, have a nice day.